Good morning, everyone. My name is Gregory Strum. I am applying for the position of a lecturer with Kaplan Medical. As I understand it, I would be teaching an anatomy review course for students who are preparing to take step 1 of the U.S. MLE examination. My area of expertise is that of orthopedic surgery with subspecialty training and experience in sports medicine. And I also taught the human anatomy course at the University of Oregon for 4 years. I believe that my experience as an orthopedic surgeon is highly relevant to teaching anatomy because of my conviction that a thorough understanding of human anatomy is the cornerstone of the good practice of orthopedic surgery. Virtually every patient we see has a condition which is anatomically based, and we need to call on that knowledge to properly evaluate and treat any given patient. My experience in sports medicine is very much the same. My teaching experience in the University of Oregon was the upper division undergraduate human anatomy course. I always told the students on the first day of class that I intended to teach the class as if they were medical students or dental students or physical therapy students, etc., any of the healthcare disciplines. I told them that because of my conviction that anatomy is the cornerstone and the underpinning of good clinical decision making regardless of the healthcare discipline they're practicing. As far as my availability, I retired from the practice of medicine 4 years ago, so my schedule is my own. I can be extremely flexible in organizing and arranging a lecture schedule that best fits the needs of the students who are taking that particular board review class. My experience in teaching, as I said a minute ago, is that of upper division undergraduate students. However, the vast majority of these students were headed to a career in one of the healthcare professions, and as such, they were preparing to take an admission test, such as the MCATs. While I don't have direct experience preparing medical students to take a board examination, I feel that this preparation process is similar enough that it would be applicable. I do have experience in writing board-style questions because I included this in my teaching. I would write board-style questions for the examinations that I gave, and I would use board-style questions in the review class that I held before each examination. I did this because I wanted the students to have experience in thinking critically, in synthesizing various pieces of anatomical information, and then bringing that to bear on solving the clinical problem that I had presented to them. Okay, everybody, we are once again at the top of the hour, so let's take 5 again. If you need a little bit more time, let me know. Otherwise, we'll meet back here in 5 to 7 minutes, and then we'll proceed on with our last hour. Okay, everybody, welcome back. We have an hour to go before our lunch break, and so we're going to use that time in a bit of a different way. I'm going to turn the tables on you, and you guys are going to do the heavy lifting, and I'm going to mostly listen. I'm going to give you a board-style question to look at, read through and answer just like you would during the board exam. And I'll give you the proper amount of time to do that based on board exam conditions. After we've done that, we'll then go over the relevant anatomy as it pertains to the clinical scenario that I've given you in the board-style question. So here we have our board-style question, which I have devised for you. We'll call it question 34. And anyone who can give me the significance of the number 34 will automatically be deemed to have gotten the right answer. I'm going to allow you to have 100 seconds to do this question because that's the amount of time that the USMLE says you will have per question when you actually take the exam. However, because this is a review session, I'll then repeat that. I'll give you another 100 seconds. And I'm going to break it down into 75 seconds to look at the question, then 25 seconds to look at the answer choices, then we'll repeat that. You need to have your answer at the end of that second 100 seconds. Then we will go over the question briefly, we will go over the answer choices, and then we'll proceed on with the relevant anatomy. Here we go. Start now. Okay, time's up. Who chose answer A? Show of hands. Who chose answer B? Answer C? Answer D? And answer E. Okay, great. I will tell you that my preferred answer is C. Obtain radiographs of the lumbar spine. Why is that? Because after having taken a history and done a physical exam, my initial diagnostic impression is that this fellow may well have herniated his disc at the L5-S1 level to the right side, and it's compromising his right S1 nerve root. So before I send the fellow home, I am going to prescribe rest, nonsteroidal and anti-inflammatory medications, some acetaminophen, and follow up probably in a week or so. But that's not all I'm going to do. I'm going to begin the workup with radiographs or x-rays of the lumbar spine because x-rays still show bone the best. And it will allow me to gain some initial diagnostic information, either positive or negative, and will help focus the MRI study that I'm going to get next. So let's go over the relevant anatomy. We have to always remember that there are three tissue elements that make up the spine. There are bony elements, i.e. the vertebrae. There are soft tissue elements, ligaments that run between the vertebrae, and the intervertebral disc that separates each vertebra until we get down to the sacrum. And then there are the neural elements, either the spinal cord or the cauda equina, depending on what level we are talking about, and then the exiting nerve roots at each individual given level. I like this slide because it shows us the three standard views that you're going to get on imaging studies such as a CT scan or an MRI scan. Up top we have the axial view. Bottom left we have the coronal or anterior-posterior view. And bottom right we have the lateral view that will become sagittal images on the study. Okay, now it's time for audience participation. The figure on the left, I have several arrows. So when I point to the arrow, you tell me what it is. Upper arrow here, pointing to, correct, the intervertebral disc. Next one down, spinal cord, correct. Just shout them out, that's fine. This one here, nerve root, absolutely. And this structure here is correct, spinous process. Over on the right we have a lateral view that shows the relationship of the exiting nerve roots to what we call the neuroforamen. This is an opening that is created by the pars interarticularis and the superior and inferior articulating facet joints of each vertebral body. We have two more structures. One, the tip of the arrow is correct, annulus fibrosus. Next, tip of the arrow is correct, nucleus pulposus. It's the nucleus pulposus that is the material that actually herniates through the annulus fibrosus and finds its way into the spinal canal or vertebral canal. This is an MRI study that would well represent our clinical scenario. On the right, we have the sagittal views. On the left, we have the axial views. That's why we have to remember what these views demonstrate. We can tell that this sagittal view is not in the midline because we don't see the spinous processes. So it's either to the right or the left. We can't tell which just from looking at one cut or one slice. However, what do we have here? Badness in the spinal canal. That the dark signal means that that disc is degenerative, has lost most of its water content, and we now have disc material that has extruded or herniated past the confines of the vertebral body and into the spinal canal. You can see that the cauda equina are displaced posteriorly. Over on the right is our transverse image, and we know that this is the L5S1 level because of what? Correct. We can see the iliac wing and the ala of the sacrum. So we know that that is the axial image at the same level as where we have seen abnormalities on the sagittal image. So, major badness right there. So the blue arrows that I'm going to bring in, what's that? Correct, that's the, well, no, it's not the spinal cord. Remember what level we're at. Correct, that's the thecal sac and the cauda equina. Next arrow, what's that? I heard it back there. Okay, yeah. That is the left S1 nerve root as it is descending and about to exit the L5S1 neuroforamen. However, our major badness is over here, and you can see that the right S1 nerve root is completely obliterated. It's probably compressed inferiorly and medially. That's what usually happens anatomically. So this, I think, is a good example of how our knowledge of anatomy leads us to the correct diagnosis, which will then lead us to the appropriate treatment recommendation. I myself, as a clinician, would say to the patient, well, after 3 days of leg pain, we know what's going on the MRI, but you probably had this and had been asymptomatic. So before we talk about doing a major surgery, let's have you rest and take those non-steroidal anti-inflammatory medications for a week or two and see what happens. If things get worse during that time, we will proceed with some urgency. All right, ladies and gentlemen, that's it for this session. Enjoy your lunch break. Let's meet back here at 1:15. Give you a little bit of extra time today. See you then.